Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Sarah Matt. She's a surgeon and health tech strategist. Today's Kevin MD article is Why Fee-for-Service Reform is Needed. Sarah, welcome to the show.
Thank you, Kevin. It's nice to be here.
All right, let's start by briefly sharing your story, then we'll jump right into your Kevin MD article.
I love it. So, to go from soup to nuts, I am a surgeon and I am a recovering surgeon. So, very early in my career, I actually switched into the tech sector. So, I've been at several startups, mid-sized places like NextGen, and then at Oracle for quite some time, running their global business for cloud and then helping the acquire Cerner. So, my business is the business of healthcare, and my business is tech. So that's where I live these days. But I still see patients. I do internal med charity care. I still teach at SUNY Upstate, and I just wrote a book which just came out last month. So a lot of good things going on right now.
All right, and your article, Why Fee-for-Service Reform is Needed, what led you to write that article in the first place and then summarize that article for those who didn't get a chance to read it yet?
Sure. So when we think about 2025, there's been so much going on. And I think that one of the things that we're missing is how to measure what's important. And
Mhm.
that's what brought me to writing this article. So when we think about the transition from fee for service to value based care, there's a lot of people out there who have really big opinions. But for me, I'm trying to be realistic. I know we have to live in this fee for service world for the time being. We can't get around that. We have to pay
Mhm.
bills today, and we have to figure out how best to utilize the codes that exist. But at the same time, I think it limits providers and their offices in lots of different ways. And one of the things I suggest in this article is twofold. First, hack the system, use the codes as much as you can, know how they work. And this means understanding how remote patient monitoring, some of your asynchronous pieces, telemedicine, how they work for your kind of practice and utilizing them. At the same time, how can you collect the data to build a business case to actually bring what you're doing in your RPM program for your business, rural medicine clinic, et cetera, so you can bring it to employers or payers or to other parts of the system. And I think this is a part where we forget that we actually have a lot of power within our organizations and within our clinics that we can collect all sorts of data. And it can be the basis for increasing revenue streams for provider offices and ultimately helping improve outcomes for patients.
And you mentioned, of course, remote patient monitoring. Just for those who aren't familiar with that whole segment, just tell us the typical conditions offices and hospitals and clinicians are using remote patient monitoring for.
So there's lots of different pieces. What I'd say is the most popular that you'll see is diabetes and then cardiac care. So we have lots of folks using continuous glucose monitoring, and that can be either sent to someone's phone or to a centralized location for remote patient monitoring. We also have lots of different cardiac conditions, everything from AFib to congestive heart failure, where some of those, again, modalities are either taking rhythms or bringing the weight of a patient back to their providers so that things can be taken care of early and proactively, as opposed to making instead an urgent or emergent problem.
And a lot of physicians aren't aware that there are CPT codes for this type of remote patient monitoring, right?
Absolutely. And I think that's the thing. Some of these codes actually can be done by your staff, by case coordinators, by all sorts of different parts of the ecosystem, and not necessarily just by the provider. So I think that when you look into these codes, think about the whole program. And again, this may not be a physician's, bread and butter to think about the codes, but as a practice manager, as other folks within the healthcare system that are dealing with billing, back office, et cetera, these are the things that can help make the difference between a clinic that succeeds and a clinic that has to close down.
Now, just because there's a code doesn't mean that they will be reimbursed, right? So, in most cases, is remote patient monitoring, are they reimbursed by Medicare and private insurers?
So for now, there's definitely certain codes that are consistently paid for. And again, Medicare and Medicaid tend to be the firsts within the system to say, yes, we're going to cover this. And then the commercial payers tend to follow. So if you're going to follow the dollar, look at Medicare and Medicaid first, look at your population. Some folks don't really take care of Medicaid patients. Some folks are only commercial insurance. So it really depends on the mix that you have. As an example, if you are managing an employer's, you know, group of employees,
Mhm.
they're going to have a specific private payer, perhaps, or be self insured. So you have to be very specific in what you're trying to bill with that specific payer.
So, when practices want to transition or better incorporate these remote patient monitoring codes in their practice? Tell us the type of advice that you would give practices to adopt this, to implement workflows, to kind of make this part of their normal practice.
What I'd say is start small and start with what feels easy. So if you're taking care of diabetic patients already and you're already calling them, you're already, giving them messages on the portal, you're already doing a lot of this work, instead of doing a whole new workflow, think about, okay, where does this fit into the coding system? Where could I now add billing codes to what I'm already doing? And I
Mhm.
think that's where you're going to find that you're doing great work that you can actually bill for.
So let's zoom out a bit. And we're talking about sometimes that transition from fee for service to value based care. It's a slow transition because there are a lot of winners and losers, right? When we go from fee for service to value based care. Tell us why some of the metrics in your article, like relative value units, they discourage innovation in digital health. So talk more about that in that piece of the article.
So I think that we've been measuring what we manage. It's easy to measure how many times Dr. Matt does this procedure. It's easy to see, oh, we're going to add on a little addition here because it took extra time. So I think we've been a little lazy in how we're measuring. It's easy to measure these things, so it makes sense. I think that instead, we need to actually adjust our metrics for the technologies of 2026. We're using AI. We're using all these different asynchronous methodologies and all these continuous technological methodologies that we weren't using 2, 3, 5 years ago. And so when you think about what's important to patients, maybe we should start billing for that. Now, value-based care is very much about outcomes, and making that full jump is really difficult, again, from a measurement perspective, and then just in how people do things every day within a healthcare office. But when we think about what's important to the patient, what are those goals that we have for our practice, for our diabetics, for our CHF patients? If we can think about what those goals are and what we're doing right now as a protocol, which parts are we billing for? Which parts are for the patient and not for something we're billing for? And where are the places where we could improve that? Hey, we're doing this, but it doesn't help the patient. We're cleaning everyone's ears out because we can charge for it. Does that make sense? Is it helping anyone? Well, for my older patients over the age of 65, they love it. Great, we'll keep doing that. But for my 30-year-olds, why am I cleaning everybody's ears?
Yeah.
Doesn't make sense just because I can bill for it.
So, as a primary care physician, you're right. The current system really rewards patients coming into my office and having me see them, where a lot of times outcomes don't necessarily need me to see them in person. A lot of remote tools certainly would do the job, right? But because of the way that physicians are incentivized and paid, we need to bring them in. Now, for those who aren't versed in health policy, you mentioned it's very difficult to change from fee for service to value based care. Sometimes you read headlines in the newspapers, they make it sound so easy. Just do this. Now, again, for those who aren't familiar with health policy, why is it so difficult? What are some of the obstacles and friction points that make it difficult to transition to a value based care system?
Kevin, this is a short podcast, but we could talk about that all day long. But what I'd say is that unfortunately, healthcare follows where the dollar is. If you can't get reimbursed, it's really hard to get doctors, offices, hospitals to do something because they need to keep the lights on. So if we're going to not pay for a procedure or we're not going to pay for this asynchronous care, well, it might be good for the patient, but I can't get paid doing it. So how can I keep my doors open? So I'd say, first of all, is the ability to keep the lights on. The second piece is that, just like I mentioned before, it's hard to measure outcomes. And you don't have a lot of control sometimes, especially if you have vulnerable populations that have a hard time getting to the doctor, that are on Medicare,
Mhm.
that are homebound. And so you're adding more risk when you do it that way. You can make a funnel and figure out how many procedures you're going to do this year, but it's hard to say that all your diabetics are going to decrease their hemoglobin A1C by this percentage.
So, tell us the type of arguments individual physicians can make if they want to incorporate some of these digital tools into their practice. You said follow the dollar. So a lot of hospital systems, they still want to adhere to a fee for service based system and maybe a little bit more reticent to transition to some digital tools. For individual physicians, tell us the type of arguments that they can make to maybe change their minds of their healthcare administrators.
One of the things we're seeing more and more docs do is take those virtual visits. And a lot of virtual visits today are absolutely reimbursed. There's very clear guidelines on that. When you take a virtual visit, it takes a lot less time for your entire office staff to prep a patient, bring them into the room, take care of a patient, finish their note, et cetera, especially with transcribing services and different kinds of software as well that's being utilized for your actual telemedicine. You could probably see more patients that way. I think that simple math is actually not a bad deal here. Can I see, instead of 4 patients in an hour, 6? Does that change how I'm getting reimbursed? Does it make it easier for me as a provider so I don't have to take as long a lunch? So I'm willing to stay later. How does that work for my office staff? Does it mean we have less no-shows? And does it mean that we have happier patients and we have better retention? So I think if you use similar metrics to what you have already, but incorporate some of those small pieces, and again, one at a time, don't go all crazy here. You know, how can you make the math work? Because again, when the dollars work, the CFO is going to say yes. When the dollars work, your practice gets to keep their lights on. When the dollars work, something's going okay.
Tell us a success story or a scenario that you've encountered where a practice has successfully implemented some of these remote monitoring codes, virtual practices, some of these digital health tools successfully and made it financially viable. And it could just be an amalgamation of cases that you've talked about in the past, but tell us, what would that look like? What would that transition look like?
So it's interesting. I have a colleague who is a cardiologist in Manhattan, and he trained at some of the hardest public hospitals in New York. And now he has a very concierge cardiac practice in Billionaire Row, if you will. And I was asking him about how he was using telemedicine. And he mentioned that it would have been great during his training if they had more telemedicine, because his Medicare patients, his patients in some of those public hospital settings, they just couldn't get to work and then get to the doctor's appointment. They just couldn't get childcare and then get to see him at the doctor's office. And so they were missing appointments because they just couldn't make it to the appointment. And you wouldn't get a no, you'd get a no show. And so what they were doing there is they were losing patients coming through the door. And so they'd have openings in their schedule, which they couldn't fill last minute. So now we have a retention issue and we have a no show rate that is off the charts. In his private practice now, he has the opposite side of that. He has very affluent financiers and other folks that are his patients. He has the same problem. Getting human beings to come to an office is really hard. They have lives,
Yeah.
they're traveling, they've got work, they got kids, they got all this stuff. He's been able to institute that since COVID, and he's found he actually has a lower no-show rate for that same population now, which is interesting because, again, in a concierge practice, you can really see each dollar for dollar as it comes through.
Mhm.
And a retention rate matters, whether it's highly affluent patients or patients who need the most help. And when you decrease the no-show rate, it means that your nurses and doctors are happier. They get to see the patients they need to see. No one misses care. And when they don't come, those patients, you see them in 3 years with a dissected aorta, or you see them in 3 years at an ED with some terrible thing happening because they couldn't make it again and again and again. So I think from an outcomes perspective, this colleague of mine is seeing better outcomes, but he's also seeing that it works for patients regardless of socioeconomic status.
So specifically virtual care, isn't it also dependent on whether Medicare and private insurers continue to cover it? From my understanding, I think Medicare had given an extension in terms of reimbursing virtual care. Do we need to keep relying on these extensions that the payers are giving us to continue virtual care?
I think that we are unfortunately at the whim of all payers. Because again, like we mentioned before, if you can't get paid for a service, it's
Yeah.
really hard to implement it and keep it going. However, what I would say is that the standard of care suggests it's good. No one's saying that telemedicine is a big problem for patient care. Is it as good as in person? Maybe not. Is it a ton better than nothing? Absolutely. And so when we think about that, it's not that it's not safe. It's that you have to make a decision for your business, for your hospital system, for your ecosystem, if it gets paid for or not, if you're still willing to do it, because it still means you can keep patients on your census. It still means you can get people through to their next appointment. It means you don't have to send people to the ER because you had a nice asynchronous discussion with them.
Mhm. We're speaking on January 1st. Happy New Year. And tell us, what do we have to look forward to? You're at the intersection of health tech and medicine. What do we have to look forward to in your area of health tech and medicine this year?
So for me, infrastructure is key. 2025 showed us that AI is blasting through. And from an evolutionary perspective, it certainly is. And it's not going to stop. The tech is not the hard part, it's everything else.
Yeah.
And what we're finding now is that whether it's in deep rural environments or in lots of urban centers, we're missing the deep infrastructure necessary to make things like remote patient monitoring, telemedicine, et cetera, work. So whether that's putting in new fiber cables throughout rural environments, whether that's bringing 5G and satellite to new areas, whatever that is, if we can't get the patient to us, how can we bring the care to them? Because when we don't, it means that we have emergency rooms completely full. And it means that people who need the care in a very emergent perspective aren't going to have space to get into that hospital. So it impacts every single person. Every person that goes to the ER because of a UTI is taking a spot that could be taken for a stroke patient or this or that. I know it's an oversimplification, but it impacts everybody, not just your rural neighbors, not just people 2 blocks from you in the Bronx. It impacts everybody.
We're talking to Sarah Matt, surgeon and health tech strategist. Today's Kevin MD article is Why Fee-for-Service Reform is Needed. Sarah, let's end with some take-home messages that you want to leave with the Kevin MD audience.
First, it's 2026. Be curious. Second, it's all about healthcare access. So I'd suggest everyone grabs my book, The Borderless Healthcare Revolution, national bestseller 2 weeks in a row in December, and visit me at drsarahmatt.com.
Sarah, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks, Kevin. Appreciate you.